Dear students, let me just check if my audio video is going fine. Can I get a quick thumbs up from all my dear students if you can see my audio video? Just give me a second, let me just check it with the great. Yes. So welcome in this session of dermatology with me, Dr. Chesta Aggarwal. Before we start, let us remind you all that tomorrow at 12 p.m. we have a very important session which is known as MedMind Ultra Combat Gamified Scholarship Test. I request all my students to kindly go through this or kindly get yourself enrolled in this amazing offer. Now here you can enroll for free using the code CHESTA10. What exactly is this test is, we will be giving 50 questions for all the subjects. You will get separate paper for first year, second year, third year, final year, intern and post intern. The top rankers will get the prizes worth rupees 10 crore plus. In addition to that, you will also have the scholarship of Unacademy up to 100%. Depending upon the rank, you will have up to 100% scholarship. So I request all my students to kindly participate in this MedMind scholarship test scheduled for tomorrow at 12 p.m. Now on Unacademy, we are also giving you 20% discount, but that offer is not remaining right now, but you can anyway go ahead and get the subscription with a very good offers. Now we are also having a NEET PG batch, that is an all educator batch. If you are interested, you can just go through it. You can use my code CHESTA10 and get yourself enrolled. The Unacademy question bank 2.0 is now available. You can use my code CHESTA10 and get yourself enrolled. Now let us start with the today's series or sessions. Can I get a quick thumbs up from all of you? Very nice, great. So the first question of the today's session is this. I hope it is visible to all of you. I hope the question is visible to all of you. The question is, we have a young female with a history of fever nodules over the shin. There is a history which reveals foamy histiocytes with neutrophilic infiltrate. There is no evidence of vasculitis, and let me show you the image. Can you see the image here? There are some lesions which are present on the foot. You can see that the lesions are present on the anterior aspect. What will be the diagnosis? So a young female presented with a history of fever, nodular lesions over the shin, histopath reveal foamy histiocytes with neutrophilic infiltration, no evidence of vasculitis, most probable diagnosis. Can anybody tell me the correct answer of this question? Can anyone tell me the correct answer of this question? Great. Now here the important points which you have to notice is, or which you have to mark is, a patient with a history of fever and nodules which are mainly present on the shin like that in this image. You have foamy histiocytes. Now please remember all my students, what are the foamy histiocytes? Foamy histiocytes are nothing but the macrophages. These are the macrophages with a lot of acid-fast bacilli. They are present in groups. And these acid-fast bacilli, they group together to form globi, and when you do a histopath, you will see foamy cells. These are also known as virchow cells. And it's a very, very classical feature of lepromatous leprosy. It's a very, very classical feature of lepromatous leprosy. Foamy histiocytes are a very classical feature of lepromatous leprosy. If a patient of lepromatous leprosy presents to you with fever and sudden onset of painful eruptions, it gives you an idea that you are dealing with a patient with erythema nodosum leprosum, which is type 2 lepra reaction. Erythema nodosum leprosum, which is a type 2 lepra reaction. So if you look at this question clearly says that there is fever with nodules and there is presence of neutrophilic infiltrate without vasculitis. So this is a patient with erythema nodosum leprosum. Erythema nodosum leprosum. Anil, it is actually, there is some issue with the with my laptop and I am not able to zoom it out. So I am very sorry. I'll try my best so that the question becomes visible to all of you. Moving to the next question. A 30-year-old patient presents with mucocutaneous lesions since 5 years. The lesion started in the oral mucosa followed by skin lesions. On examining, his skin lesions are raw and painful. There are irregular ulcers noted in the oral cavity. The Nikolsky sign is positive. His biopsy is classical of which of the following condition? Pemphigus vulgaris, Pemphigus foliaceus, bullous pemphigoid, or cicatricial pemphigoid? What will be the answer? So you see the oral mucosal lesions plus Nikolsky sign is positive. This is a very, very characteristic feature. Nikolsky sign positive with the lesions on the skin in the mucosa. This becomes a very, very classical feature of Pemphigus vulgaris. Now please remember, whenever you get a question of vesiculobullous disorder, please remember we always need to look for the lesions, whether it is limited to the skin or it is also involving the mucosa. If it is involving the skin, what type of lesion is this? Whether it is tense or flaccid. When it says that you have tense bulla mainly present on the periumbilical skin or the proximal part of the lower extremity, think of bullous pemphigoid group. Usually the mucosal lesions are absent or missing. But if you see flaccid lesions with involvement of mucosa, very characteristic of Pemphigus vulgaris. But if you have flaccid lesions without mucosal involvement, it's a feature of Pemphigus foliaceus. So please keep this in mind whenever you have a question of vesiculobullous disorder. That is a very important feature. Okay, remember that Nikolsky sign is negative here. Nikolsky sign is negative. So that is again a hint. Nikolsky sign is negative here, but Nikolsky sign is positive in both Pemphigus vulgaris as well as Pemphigus foliaceus. So very well done all of you. The correct answer of this question, is a 30-year-old male presented with mucocutaneous lesion. The answer is option number 1, that is Pemphigus vulgaris. The correct answer is Pemphigus vulgaris. Anybody with any confusion? Great. Moving to the next question. Again, I'm very sorry I'm not able to shrink it up, but please answer. A middle-aged man presented with a single anesthetic hypopigmented patch on the forearm, which of the following is true? Single dose of ROM can be given. When it is left untreated, blindness, nasal collapse and testicular atrophy are the expected sequelae. He should be given Dapsone, Rifampicin, Clofazimine for a period of 6 months. And serology or PCR are the helpful test for diagnosing these patients. A middle-aged man with a single anesthetic patch, what is the answer? A middle-aged man with a single anesthetic patch. Great. Now let us discuss some of the important concepts which you all need to know for the discussion of or the treatment of leprosy patient. WHO have divided leprosy patients into 2 groups. One is paucibacillary and another is multibacillary. Now only on the basis of clinical grounds also you can tell whether it is a pauci or a multibacillary patient. If the skin lesions are 1 to 5, or if the nerve is involved, it is only one nerve or no nerve, and the slit skin smear is negative. All these 3 or either of these 3 will give you an idea that the patient is of paucibacillary type. But for multibacillary, the skin lesions are more than 5. If the nerve is involved, it is more than equals to 2, and if there is slit skin smear positivity, it will give you an idea that you are dealing with a multibacillary type of leprosy. For paucibacillary, we will give Rifampicin, Clofazimine and Dapsone, the MDT kit for 6 months. While for multibacillary, we give Rifampicin, Dapsone and Clofazimine MDT kit for 12 months. So you give 3 drugs for both multi and pauci. The only difference is in the duration. So if we go back to the previous question, the question clearly mentioned that we have a man with single anesthetic patch. So this is a patient of paucibacillary. This is a patient of paucibacillary leprosy. In paucibacillary also you will give 3 drugs for 6 months. The chances of having the late sequelae like blindness, nasal collapse, testicular atrophy, it is more frequent with multi, not with posse. And serology, please remember, for leprosy patient, we only do clinical diagnosis. Just a clinical diagnosis is sufficient for starting the treatment in these individuals. Understood? So that was the third question for the today's session. Moving to the next question. Please tell me the answer of this question. An 8-year-old boy from Bihar come with symmetrical juicy papules and nodules which are present on the face and the trunk. There was hypoesthesia and nerve thickening. There was fever a few years back. What will be the likely diagnosis? What will be the likely diagnosis? Lepromatous leprosy, post-Kala-Azar dermal leishmaniasis, borderline leprosy or mycosis fungoides. What is the correct answer here? What is the correct answer? Very nice. So there are few hints which you have to keep in your mind, and yes, I can see a lot of students who are correct also. The hint here is first that the patient is from Bihar. The second is symmetrical juicy papules with hyperpigmentation and there is no nerve thickening. Remember, in the patients of leishmaniasis, sometimes after 2 years of recovery from Kala-Azar, patient develops what is known as post-Kala-Azar dermal leishmaniasis. Now this PKDL has a very characteristic presentation. It will have early hypopigmented stage and a late nodular stage. Early hypopigmented or a late nodular stage. There will be no nerve loss, there is no loss of sensation, and that is one of the very important differential diagnosis. You can easily rule out lepromatous leprosy patient because there is normal sensation. Plus the nodules, they are asymptomatic, unlike painful nodules which are seen in the patients of lepromatous leprosy. Okay? So that is a patient of post-Kala-Azar dermal leishmaniasis. It's a patient of post-Kala-Azar dermal leishmaniasis or PKDL. Moving to the next question. Tell me the answer here. Everyone. A 24-year-old female who is little obsessed with the hand washing come to dermatology OPD with a patchy hair loss in the right temporal and occipital region. Examination reveals non-scarring alopecia with multiple small broken hair. Scraping from the scalp shows mild inflammation, perifollicular hemorrhages, surrounding lymphatic infiltration. What is the most likely diagnosis here? Very nice, amazing, great. Now please look at the patch. The answer, you are all right. The answer is trichotillomania. I request all of you to please look at this patch right now. There are two features which help us differentiate trichotillomania from other two or three options. There is multiple broken hairs. There are multiple broken hairs of unequal length on the alopecia patch. There is multiple broken hair of unequal length on the alopecia patch. Because of pulling, the patient presents with perifollicular or intrafollicular hemorrhages. Perifollicular or intrafollicular hemorrhages. Because of presence of pulling effect, the patient will have a very classical perifollicular and intrafollicular effect. In the question, they sometimes give you a history of pulling, or they will give you a history that patient is not well mentally. He is constraining himself inside a room, not interacting with other people, sudden family dispute, sudden stress. You will get all these history, which is very, very important. Ma'am, symmetrical lesions in leprosy points multibacillary. Yes, you are correct, Anil. The symmetrical lesions, they points towards the multibacillary type. So the answer here in this question is option number 4, that is trichotillomania. Option number 4, that is trichotillomania. Moving to the next question. Moving to the next question. What is the correct answer? A primary gravida female presents with erythematous skin changes and lesions with multiple pus lakes. Which of the following should be the treatment? What will be the correct answer here? Very nice. Please remember, a pregnant female with erythematous lesions developing multiple pus lakes. Can anybody tell me what is the diagnosis here? This is a very classical image and question from a disease known as Impetigo Herpetiformis. Can you tell me what is Impetigo Herpetiformis? Anyone? It is nothing but pustular psoriasis of pregnancy. It is nothing but pustular psoriasis of pregnancy. And please remember, when you have severe generalized pustular psoriasis of pregnancy, you need to give a drug which is very quick in its action, and that is why the treatment becomes option number 1, that is corticosteroids. This is the only indication of giving steroids in the patients of psoriasis. Otherwise, we never give systemic corticosteroids. Only when we need it, we need a very quick action like in pregnancy. Now, can you tell me, if for any reason, if these steroids are contraindicated in a pregnant patient having generalized pustular psoriasis, what is the next best option available with us? Anyone? What is the next best option available with us? How can you treat a patient of psoriasis, severe psoriasis in pregnancy? Please remember, the second best possible drug is, second choice which is available is cyclosporin. Again, it's a quickest acting drug or quickest acting anti-psoriatic drug. You will not give Soralin Shreya. Soralin is a teratogenic drug, contraindicated in a pregnant female. Contraindicated in a pregnant female. Clear all of you? Now moving to the next question. A 12-year-old child, Raghav, otherwise healthy, presented to the dermatology OPD with erythematous follicular papules on the trunk. There are areas of normal skin within the lesions. There is thickening of palm and sole. The child is suffering from. You have sufficient hint given in this question. I want everyone to read. Follicular papules with areas of normal skin, that is island of sparing. Thickening of palmoplantar skin. Yellowish discoloration. I am giving you hint. Yellowish discoloration. Shreya, if in the last question, if the patient is not a pregnant patient, then the treatment of choice becomes acitretin. Because for pustular psoriasis, the drug of choice is acitretin. Okay. The correct answer, I think nobody have given me the correct answer. Only one student, Priya. It is Pityriasis rubra pilaris. Please remember, the correct answer of this question is Pityriasis rubra pilaris. It's a very classical CARD14 gene defect. Patient presents with follicular papules. It gives a very characteristic appearance, and which is known as nutmeg grater appearance. Nutmeg grater appearance. And in these individuals, you will see classically islands of sparing. You will see islands of sparing. There are few areas which are completely spared. So you have history of island of sparing, presence of follicular papules in a young individual. This is a very classical feature. How to enroll for the scholarship test? Ram, just go to the website of Unacademy. You have to put a code. Code is Chesta 10. And if you put this code, you can enroll yourself for that scholarship test. It is a free test. Anybody can use this code and get access that test. Okay. Remember that the top students will have amazing prizes. in the form of iPads, the pen tabs, watches, laptops, etc. Along with that, you can get Unacademy subscription up to 100% scholarship. Depending upon your rank, for the first few ranks it is 100%, for the next it is 75, 50%, etc. So if anybody interested in getting that scholarship test enrolled, don't forget to use this test. Okay, great. Now let's move to the next question. I think we had discussed this question yesterday. I remember doing that yesterday. Anyways, can you all do this for me? So I told you that in the patients of atopic dermatitis, you develop a very characteristic white dermographism. There are many other minor features which you see in the patients of atopic dermatitis, and one of them is pityriasis alba. Now here in this question, the question is actually asking you about the faint hypopigmented lesions on the face which is present in the patient with atopic dermatitis. So in atopic dermatitis patients, you develop what is known as pityriasis alba. I think this question we have discussed yesterday, so I am not giving much time here. Moving to the next one. Did we discuss this question also? I guess. A patient with eczematous rash on the wrist in gel and comb classification of hypersensitivity. This is a very classical example of. So allergic contact dermatitis, what is it? Allergic contact dermatitis is a type 4 hypersensitivity reaction, and please remember, on the wrist it could be because of jewelry and it could be because of wristwatch, etc. Okay. So the answer to this question is option number 2, that is type 4 hypersensitivity with a very classical allergy to the nickel. Type 4 hypersensitivity with a very classical hypersensitivity to the nickel. So with this, we are done with the today's session. I hope you have enjoyed this brief session of 10 questions. But before we end, I just want to stress again on this MedMind scholarship test. I request all my students to please participate because it's a free test. You just need to get yourself enrolled. There are separate tests for different years like MBBS 1, 2, 3, 4 as well as intern, post-intern. The top students will win the rewards worth rupees 10 crore plus depending upon the gadgets or their rank. They can even get 100% scholarship, up to 100% scholarship depending upon their rank. So thank you all of